All right, thank you. Next to private payers perspective, and Lee Newcomer will be is coming from UnitedHealthcare and will give us some thoughts.
So good morning. I have been here before, as many of you have as well, and usually I start any talk I give with a graph that shows U.S. household income and the amount of money it takes to buy an insurance premium for and pay out-of-pocket expenses. We are about 9 to 14 years away from where those 2 points intersect, 9 to 14 years, and at that point it'll take 100% of average U.S. household income to buy health care. And we just forego things like education and housing and food. It's okay. We've got other priorities. So we have to address cost, and it's naive to think that we are not going to have to address cost, and yet it's only mentioned once on the right side of the table, and my colleague from CMS is saying I can't look at cost because of regulatory issues, is handcuffed. And I would argue that that's magical thinking. So I want to talk about 3 points today here. The first is that even though immuno-oncology is extremely exciting, and I've been really invigorated by what I've heard in the last 2 days here, it's deja vu all over again. We still have to develop evidence. We still have to find who are the right patients for those therapies, and we need to understand what types of nuances are necessary to get the therapies in the right hands. So I don't think our need for evidence disappears or changes at all, even as exciting as the technology is. And in the US, we have a propensity to rush out and start using that new technology way before the data is complete. That's been our tendency in everything. We like new things, and we want to use them. I do too, but I'd like to have enough evidence to know who would be the right people to benefit, because if we give it to folks who are not going to benefit, we are wasting those same precious resources. So the second is that I think we're going to have to think about prioritization of our efforts. As I look at the CAR-T data, I keep seeing and hearing it talked about, for example, in ALL as the good therapy for fourth or fifth line. But the data is so exciting, why are we not doing the trial almost immediately as first line? I could save, believe it or not, a lot of money paying for a very expensive CAR-T cell therapy in ALL if I didn't have to go through 4 other lines of therapy, including transplants and so on. So let's get those studies done as quickly as we can and find out what works. We are going to have to prioritize what we do. I am just in the middle of, for example, of an acrimonious debate with an academic institution not too far north of here because they're requesting a PET scan on a 1A breast cancer patient. And I'm looking at some breast cancer experts in this room saying, what? Quite frankly, I'm spending more money fighting this in the regulatory arena than I would have been just to pay for the scan, but I'm trying to start establishing there are things we're going to have to give up in order to pay for these more exciting issues. And that patient's course isn't going to be affected by her PET scan. Just isn't going to make any difference. It's wasted money. Third point, let's talk about waste. There are many things that we can get rid of in the healthcare system to help fund these kinds of technologies. If you pick up your New York Times this morning, you'll discover that something as simple as the vial size of your drug could save $2.4 billion for one agent. In the next 5 years, because a manufacturer is only producing a single vial size, $2.4 billion worth of drug will have to be thrown into the trash can, and we will have to pay for it. Why are we doing silly things like that? We can fix those kinds of problems. And perhaps to me, the most tragic waste, the one that we could do the most about, is patience. I just gave a talk last Friday where the headline was, All Lives Matter. We should not take a single patient in this day and age with all of these opportunities and not put them in a clinical trial. Because if we have an opportunity with a new gene mutation, if we have an opportunity with a tumor that could be used with immuno-oncology, let's not treat them offline. Let's put them in the trial. And pharma, my challenge to you is let's make those trials accessible. Don't make Lee Schwartzberg take his patient and send them off to New York City. Most of them can't go. Get that trial to them. And let's have the opportunity to move quickly so that we can actually get the answers we need. My moonshot challenge to Vice President Biden is let's get 100,000 people on trials in the next 3 years. It will take work, it will take effort, but we can do that. And if we did, this would be a much more informed debate 3 years from now. We'd have the data that we need.